So I think what we'll do to start with, we'll introduce everybody that's on the call. So can I start with the team at Compton?
Hi everyone, I'm Marianne Grant and I'm the Partnership Development Manager here at Compton. I'm Karen Jutler, newly appointed Senior Research Associate here at Compton.
Lovely, great to meet you. Can we go to Claire?
Hi there, my name is Claire Craig. I'm a co-director of an interdisciplinary research cluster called Lab for Living that brings together design, creative practice and health.
Fantastic. Libby?
So I'm Dr. Libby Salno. I'm a palliative care consultant and senior honorary clinical academic at UCL and St Christopher's. And I recently did my PhD evaluating compassionate neighbours.
Fantastic. Thank you. And colleagues at St Christopher's, can you introduce yourselves way back?
Hello, sorry we're so far away. I can't work in the Zoom option on this thing. I'm Steph Turner, Community Participation Lead at St Christopher's.
And I'm Andrew Goodhead, and I'm late, which I apologise. But I'm the Spiritual Care Lead, and over the recent months I've had a responsibility for our community action work.
Fantastic, thank you. And colleagues from Hope? Who's on from Hope?
Hi, I don't know if you can hear me. I seem to be having a my name's Michael Sharp. I'm the CEO of Hope, and apologies for joining in late.
That's okay, no problem. Have you got a camera, Michael?
It doesn't seem to be working. I'm working on it.
Okay, no problem. Well, welcome. It's Claire. And I'll just introduce us all. That's Hospice House. I'm Claire Henry, Director of Improvement and Transformation.
I'm Amber Morgan, Programmes Coordinator.
That's Carl, Head of Grants. Matthew, Grants Coordinator.
Thank you, that's great. So we've got everybody, hopefully Sally's going to join us from the Isle of Wight as well. So I'd like to welcome everybody, and which we've done. Can you go to the next slide? And just to remind people what the aim is, it's about how we're going to really work together around communities and improve relationships. So next slide. We've done the introductions. I'm going to hand over to Libby shortly around talking about public health approach. Then colleagues from Compton talk about the work that they're doing. Great work that Claire's doing that I heard about at a conference, at an event recently. And then we can sort of close and we'll finish at 12 o'clock. So next slide. So I'd now like to invite Libby to talk to us. I shared your model with the teams at our project day, but it'd be brilliant to hear from yourself. So over to you, Libby. Thank you.
Now, do I go forward with, or will you just?
If you just say next slide, we'll do that for you. That's all right.
Okay. So I just going to talk just for 10 minutes. So a really brief bit about new public health approaches, kind of the academic and principle kind of behind them, a tiny bit about my research, which I'm happy to share in a bit more detail. And I think you've heard a bit about it before, but I also want to have some time for questions because that's kind of one of the key things. I don't just want to talk for the whole time. So next slide. So the first thing is about some of the drivers for what is happening if we look at the term public health in general. So public health is a hugely broad area. Obviously, it's around reduction, prevention, harm minimization, etc. But if we look at public health and palliative care, there's all the different issues. So there's kind of the issues around opiate access, trying to improve, so the Lancet Commission, the Global Commission on Palliative Care, recently looking at the global inequity in access to opiates and what kind of government systems along with health services systems need to change to allow that inequity to be managed. There's kind of access to services for people from different areas, different groups, and that inequity. The WHO has had since kind of the late 80s a public health approach. It's espoused a public health approach to palliative care. So that's been long standing, but they've looked more at these kind of issues of access, integration of palliative care into mainstream services, and opiate kind of law reforms. And then there was the big World Health Assembly resolution in 2014, which is a really big step change in saying, well, actually, we need this to be universally accessible, and palliative care was suddenly kind of seen alongside these really big global pushes to achieve equity and access to all forms of healthcare. And there's also the kind of idea of palliative care and pain relief as a kind of a human right. So there's always kind of different narratives of how palliative care goes beyond just a kind of biomedical approach. And then kind of coming around to the other side of it, the approaches that we'll be talking a bit more about now, and obviously the approaches you're involved in, which is around acknowledging and then addressing the social determinants of how people live and die, what health means, where place of death comes into this. And then the kind of participatory approaches, whether we're looking more at kind of volunteering or kind of user engagement, or the kind of community development approaches. So if you kind of talk about a public health approach, actually all of these different aspects are included. So with such a broad term, it can lead to quite a lot of confusion. So I think it's helpful to kind of acknowledge where this work sits, and we are one part of this broader approach. Next slide, please. So new public health. So I think I did this on a broader, on a kind of Mac screen. So some of my diagrams are squished in. So looking now at new public health specifically, so participatory approaches. Some of you may have seen this kind of set of interconnected cogs that Alan Kelleher and Julian Abel have put together. But I think what's quite helpful is how they've kind of visually represented this, because when we're looking at new public health approaches, so kind of participatory approaches that we'll go into in a bit more detail in a minute, they don't exist in separation from excellent specialist palliative care, availability of opiates, ability of people to actually come and meet specialists, etc. But down at the bottom, if we look at the bottom blue cog, specialist palliative care, that's kind of often what we think about when we think about good end-of-life care. And obviously, without availability of drugs, without stringent drivers in the community, without end-of-life care on the hospital wards, good deaths can't be achieved. But it should be seen in its broader context of these interconnected wheels. So looking up to the next one is generalist palliative care, which is obviously all practitioners in whatever way, understanding what their role is in supporting good end-of-life care for patients and carers. But then moving up, we've then got these kind of broader societal ones. This is where you are getting non-clinical, non-healthcare staff, the broader community within which someone's living, acknowledging their role. And that's where compassionate communities come in, the kind of the broader sense of who's living among them, from kind of, local pharmacists, local shops, neighbours, friends, carers, that whole range of different non-clinical components which are important in supporting healthy attitudes to death and dying, and people to die in the place of choice. And then more broadly is the red one, which is the bigger kind of civic programme, which goes beyond individual episodes of care, individual relationships, individual networks, and looks kind of at a civic approach. So looking at what councils, what schools, what national policy is doing really. And so all of these are interconnected, and if one is stuck and is not working, then actually you can see how the rest of the pieces find it harder to work, because if we're going to achieve really significant change, then all of these needs to be joined up. And it's not saying we don't need the biomedical model, which some of the kind of early push was like, actually we just need to move, communities know it, or communities know a great deal, and that's represented here. But you also need that specialist palliative care cog, but you also need a kind of broader policy change to understand actually talking about death and dying, supportive policies to fit with all of that. So I think that's quite helpful when we look at the new public health. These are the components within it. Next slide, please. So principles of new public health, which set it apart from these other kind of more traditional public health, which is around kind of opiate access and policy, is participatory. So it, by its very, very definition, is not top down. And so it sits in contrast to the kind of participatory project, the policies projects looking at, changing, say, seatbelts, or kind of non-smoking, those kind of space. So there's big top-down policies. This is very different. This is bottom-up, working with people who have direct experience or will be affected by the issue, and working with them to find solutions. And there's a focus on social justice and social change, so it's active. It's not about just communities doing things by themselves, although the idea is that you may support communities to get to be doing that. But it's about partnerships, and it's acknowledging that both have a role to play. And so you then get into this interesting point where you're looking at whose knowledge do you privilege. So you've got lay expertise and you've got professional expertise. And that's where some of the subtlety and some of the really rich learning, I think I've certainly come to, comes out in this. And that's where I think these kind of groups are really important to begin actually understanding what this means in practice, because it's quite easy to say what partnership and collaboration means. But when it comes to it, and I'm sure you guys have had experience of this, what does it actually mean in practice? How can you authentically engage with people who have got very different perspectives and often actually don't agree with what you're saying and want to do something completely differently? So next slide. So this is something I did a few years ago with a colleague who she was doing an action research project at the end of life looking at schools. And basically the kind of triangle, some of you may have seen this, but it's I was trying to allow us to understand what the different aspects of new public health are. It's not a one size fits all, and there's different levels at which you can engage with this. But there's, in all community development, in all kind of participatory work, there are these kind of ladders of participation, and some of you may have seen them. And basically they kind of go from the bottom, where you're just kind of giving people information. So rather than having a kind of two-way dialogue and finding out their perspectives, you're kind of sharing information. And that's an important step. You know, that's not to say that's not important at all. You know, without information, people can't make decisions. And so you do need to be sharing that information. But it's not really working in partnership because it's not two-way. And then the next step up is consult, where you may go and gather people's opinions. But again, there's not really a dialogue. You might go and survey or ask people to write their thoughts and leave them in a box. So you're trying to get some form of impact, information from the community about their feelings about a new service or what good care would look like. But again, you're not collaborating. You kind of take that away and then decide what to do with it. And you can obviously choose to disregard it. There's not much power shifting within that. Then as you start to move up towards kind of co-production, collaborate and empower, you're having much more of a meaningful dialogue, and you're actually beginning to take what patients, carers, community members, the general public say, and sit it alongside your expert knowledge. And that is where you get the real change in terms of actually we're acknowledging what experiences and expertise these people bring, and we sit them alongside ours. So we're not privileging, we're not saying, well, we're right and we'll take when it fits in with what we say, actually we'll go with it, but if not. And a lot of PPI, a lot of user involvement goes like that. You kind of, yep, that's great, have that representation, but if it doesn't kind of fit, you're not going to change your entire strategic plan because people have said something differently. Whereas really good engagement would mean actually, well, we need to go back to the beginning and really think about that, because if this really doesn't resonate with the people we're talking to, maybe we need to review it. I mean, there's always issues of representation, and, you know, 2 or 3 users aren't necessarily going to represent an entire community. So you have to also understand, you know, who you're saying you're representing when you're there. But really to allow you to start moving up that ladder, which all of this work ideally should be getting to, then you do have to have that acknowledgement of power and to begin having a kind of equitable dialogue where you're actually saying, yes, we understand that. Let's go out and get broader perspectives on that. So you kind of want to get as broader understanding as you can, but then to shift the power. So we just kind of put this together to try and help people who are beginning to sit out on this work, map maybe where they currently sit, and then look at where they might like to get, and then what kind of processes are in the boxes that kind of help you to move up that if that's what you want to do. Next slide, please. So I'm just going to look at some of the, like 3 papers that show some of the evidence, because there's evidence really building in this area. So this is an amazing paper, this is open access, and many of you may know this, but it's a big meta-analysis of over 300,000 patients, people actually, who, not patients, who were this big study. The authors wanted to really understand what the relationship between social relationships and health are, basically. There have been loads of smaller studies saying they're really significant, they really impact on either health or morbidity or mortality. So they did a massive meta-analysis, and they found some really shocking, astounding views that were picked up in the press in 2010. And basically it shows that they map, if you look at the appendices, there's a really interesting graph, they map all of the major public health threats like smoking, alcohol, obesity, air pollution, all of the different things like that. And what they found was they mapped all of those. What trumped all of those was whether you had a social network or not. And if you didn't have a social network, you were 1.5 times more likely to die early than those people who had a good social network. So this kind of really was one of the key papers that elevated the whole kind of public health notion of loneliness, because actually without a social network, it's as damaging as smoking 15 a day cigarettes, you know, that. So it got picked up by all the press because, you know, this is really significant. So that was published in 2010, and there have been lots of other papers since, and Julianne Holt-Lundstad has written lots of other stuff actually that's very interested in around this. But that was a kind of big kind of seminal paper that said, look, here is the actual number to demonstrate what we're doing has a real impact. Next slide. And then the next one, this is Julian's paper that was published just last month. And again, it's an observational paper, so you can't draw any conclusions around causality or kind of what this is. But what they were looking at down in Frome, they've done a whole new general practice model, really. It's not about end of life specifically. It's not about frailty. It's about anyone who's had frequent hospital admissions. Obviously, within that is a large proportion of frailty and a large proportion of those at the end of life, but it is completely across a population approach. And they showed that within Frome, the small area in Somerset, when they instigated essentially a kind of social prescribing, community engagement, connecting people into resources in their local community after frequent admissions, kind of coordinated by a GP centre, their unplanned emergency admissions dropped by 14%, whilst in the rest of Somerset, who didn't have this, they went up by 30%. So again, you can't. It's not a kind of test that says, yes, this is the intervention, but in terms of observational studies, it was really compelling to say when we start engaging people's local community networks, that has a really significant impact on their healthcare, which again kind of backs up really the study that was before. And next slide. And this is Catherine Walsh and the team up in Lancaster's review. They did a randomised control trial looking at social action, which included kind of from a range from befriending, kind of quite controlled befriending intervention, up to quite free community development compassionate neighbours projects. Now, they didn't actually demonstrate any outcomes on their primary outcome measure, but on their secondary outcomes, they did begin to show some of the impact. And I think this really demonstrates the difficulty of trying to demonstrate outcomes for hugely variable, community-based, locally determined and locally driven projects, such that the outcomes aren't going to be the same for every single one. So trying to kind of pull that many studies together and then put one outcome that all of them are going to demonstrate on is really tricky. So we'll talk a bit more about the problems for evaluation that this study highlights. Next. So my PhD was evaluating the Compassionate Neighbours project, which had been started at St Joseph's in 2012, and then the pilot was run in 2014. I did a mixed method study. I did not want to presuppose what outcomes were. So I had ideas about what I thought this would do, but knowing what some of the previous studies and where they failed on is that if you me as someone who's not part of the project decide that I think this is what the outcomes are likely to be, there's a significant chance that other people are not going to feel the same with that. So I had a really open, a really emergent methodology, which allowed me to ask people, all a range of stakeholders, even people who I hadn't even anticipated benefiting at the beginning, to be included, to understand what are you saying matters and what are you saying changes for you or not, and what are the good things and what are the bad things of this. So a really open method. So we haven't got time to go through, obviously, the kind of full conceptual model that I developed, but I want to, next slide, talk about just the three key results that came out of this. The first was that that people both being visited at the end of life and also the compassionate neighbours, the people at home being visited and the compassionate neighbours, all said, we have changed how we are in ourselves. We're feeling less lonely. We're feeling more positive about life. We feel connected. We've started doing things. We're going out. We've lots of the compassionate neighbours spoke about. I've now got a mobile phone. I had no one to call before. I wasn't in any kind of network. I had no reason to have one. I'm now back on the map. There are all these kind of amazing quotes, sensing like I am now part of something that I now have a reason to get up for in the morning, and I have a purpose and value in my local community. And so what was interesting is that the compassionate neighbours that benefited more often than those being visited at home, the community members. And what often the community members are talking about is, yeah, it's nice to have someone to visit us, but actually what we're more interested in is having control. So they didn't necessarily just want another person turning up, having a cup of tea and leaving. What they wanted was a sense of control. And where the community members really benefited from being involved in this project was when they were able to exert control. So they were able to say, you know what I really want, rather than you coming for a cup of tea here, is I want you to take me out, I want to do this. And people began to take a much more active relationship with the compassionate neighbour, advising them on, some of them compassionate neighbours weren't working, and then they would start advising them about how to get into work. So this kind of sense that actually to get the benefit from a relationship, it can't be passive, it needs to be reciprocal. And actually one of the issues with many befriending projects is they enforce this kind of passive nature. You can't swap numbers, you can't go anywhere, you can't make a cup of tea. And so actually to develop a real friendship is quite difficult amongst those constraints. But where we saw people being visited at home having really big changes is when they were able to actually be reciprocal and to engage in a relationship that was often outside the kind of the standard befriending kind of protocols. We also saw there was a new relationship between the community and the hospice. And this is quite interesting because there can be a bit of a conflict between a community development project that is out to try and develop skills, to develop resilience, to grow the community's capacity. But then if you've got a hospice kind of controlling it, there can be quite a difficult conflict within that. And I was quite interested when I started the research to see how this would play out. But what was interesting is that actually there was a change in relationship between the hospice and the community, the kind of broader community within which Compassionate Neighbours sat. And so rather than the hospice saying, look, this is the training, this is how it works, or these are the rules, this is how you will fit in with this, there was a sense of kind of mutuality. So the hospice was taking back feedback from Compassionate Neighbours and saying, okay, we actually hear that and we will change how we do things as a result. And then you could begin to see how this kind of slight shift in power, a slight shift in kind of respect between the two began to change. So the hospice was asking Compassionate Neighbours to come and represent them at CCG, local council government meetings. So there was a kind of real respect that actually we understand that you have views that actually we support, and we kind of would like you to go and speak on our behalf. There was a kind of a change in power and in how the hospice was treating the community. It wasn't about the hospice being in charge and telling them what to do. It was saying, actually, we support you in whatever you have to say to the council, to CCG or CQC meetings, we support you in that. So it was going beyond service delivery, where the hospice was saying, this is what I would like you to do, come and you fulfill these slots. It was actually the community saying, well, this is what we think we should happen.
Libby, 2 minutes.
Brilliant. And then the last thing changed was that we began to see how this could work beyond that. So yeah, just the last bit was we saw compassion and tolerance acting beyond that. So those 3 findings were the key ones. And behind this, I then wanted to understand, well, how does this work? What are the drivers changing this? And the 3 drivers were power, reciprocity, and agency, which are all interconnected. So if you begin having a change in relationship whereby the person who's visiting and the person at home are equals, their peers, seen as peers, it's not that the person visiting is kind of coming to save the person who's lonely or save or sort out their loneliness. You know, that can't be sorted out even from loads of visits a week. You can't change that. But to support them, say, I'm here with you, I understand many of these feelings I have, but we're peers, let's work this out together, and I need your support as much as you need me. And also between the hospice and the community. So once that power was subtly shifted, that allowed reciprocity. So the hospice and the community could talk to each other in a different way, and those being visited and at home could talk in a different way. And so there was a sense of people enacting kind of reciprocal relationships. And once you start acting like that and having something to say and something to participate, then you get agency, because then you start understanding that actually your actions count and what you do changes things. And so that is the key driver for actually getting those impacts. So this is my last slide. So the last take-home messages. The first thing is this kind of work, new public health approaches are not new services. And that is if you call them new services, then you're already saying no power will change. There'll be nothing. This is the same as usual. It's that whole thing. Definition of madness is thinking, doing the same thing, achieving different outcomes. You know, things have to be named differently, so people understand the principle. So they're not new services. They're not interventions that can just be standardised and just delivered by anyone. The beneficiaries may not be who we expect. So it may not actually be those at the end of life who are the key beneficiaries. It might be the people delivering it, because they've got the bigger opportunity to develop that agency as part of the network. The impacts that we saw, which were really significant, facilitated by partnership, some really uncomfortable questions and shifting power and conversations. It wasn't straightforward. There were some really difficult conversations. And if those don't happen, you're almost not on the right path. Some of that should be difficult and slightly awkward. And organisations need to reflect critically on their role within this. So organisations are not just starting and delivering and running a whole new service. You're actually just trying to be a catalyst, really, and support what's there. And so without kind of thinking critically, about that role, then you can just slip back into service delivery, and we're just running a new volunteer befriending project, which is the same and that can have good impact. But if we're looking for a new public health to do something differently, then you have to be having that kind of critical dialogue. And it helps if you have someone slightly outside your organisation to be able to reflect and say, well, why are you doing it like that? And actually, you know, have you thought about doing something differently? And maybe they have got a good point. Maybe you should change it in that way. And that's where kind of the creativity really comes from that conversation. Thank you.
Thank you very much, Libby. Your enthusiasm is overwhelming. It's brilliant. I think we could all listen to you for ages. That's brilliant. Thank you. Have we got any questions from our teams?
Mute. Do you want to also?
Yeah, just unmute everybody. Yeah.
Yeah.
Marianne, any questions or comments?
Apart from, I'm not quite sure how I'm going to follow that one.
I'm sure you'll follow. I was just going to say, Libby, what we could do is send all the links around with the papers so people can access them really easily.
Definitely.
If that's okay.
There's more as well. So if people want a kind of resource page, I could just send you with all of the papers. That's fine.
That would be fantastic, because I think it's great that we can build on that evidence base.
And yeah, there is an evidence base now, which is so exciting.
Yeah. So carry on, Karen.
Now, I've got a quick question, Libby. I was just wondering, how diverse were the communities in which you were doing your research with?
So really diverse. So the majority were non-white, so mainly Bengali and Somali, with the smaller group was then white working class in Hackney, and a lot of, so really diverse age range as well. So kind of IT engineers working in the city, right up to kind of older Afro-Caribbean 80-year-olds who are doing it more on the phone. So really, really diverse, actually. Almost no kind of your classic volunteering. You look at kind of the volunteering in the hospice normally, which was kind of older, retired, possibly semi-professional, white. This was almost exclusively younger or much older, non-white, living locally, often not with English as a first language. So that was part of the thing where we were saying, well, actually, we can't run it like other volunteering organisations. One of the big fights was doing statutory and mandatory training, which are these workbooks, and would have been completely exclusive to people. We would have been excluding large proportions of the community who did not have written English in that level. So we had a big fight within that, and that's where some of these uncomfortable conversations saying, well, if we do that, then we're just going to have the same volunteering project that we always have. So how can we look at confidentiality, wheelchair training, safeguarding in a way that actually won't exclude people, and kind of in language that people understand? Because if you're not asking for them to be professionals, then you don't need safeguarding level whatever training. You need to understand how to escalate something safely if you're in someone's house and you're worried. So kind of using words like, if you're worried, kind of privacy rather than kind of confidentiality. Yes. So, you know, using the language is really important. And that's why we had a community development organisation helping us with some of this, questioning us at every single point, saying, no, 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 what does that language mean? If you use that, you exclude people, no. And so having the timing of the training so that people could pick kids up, drop kids at school in the morning and pick them up. So you can't have anything running beyond 10 till 2, because if you do it 9 to 5, how does childcare work? People who need to pick kids up automatically can't come, you know, and then doing it on the weekends as well for people who actually are working but really can't take a day off work to do this, but, you know, work doing it in the evening. So we totally shifted a whole kind of volunteer model of training to try and not let it be so exclusive, led by the community saying, well, actually, I need to pick my kids up, so I can't be here at 5 o'clock.
I think I'm just thinking it might be nice if we invite you to another webinar to talk about sort of some of the real practicalities as well, if you've got time, because I'm conscious we've also got 2 other speakers, but I think this is what's really getting into the nitty gritty, which is fantastic. So I don't know what other people think, but if you'd like, we could, if Libby's free, invite her to another webinar, and we can obviously connect you all up.
And you could send some questions before or something, so I can
brilliant.
Work up the answers to things that are pressing.
Yeah, if you want, and we can sort of set an email up if we want to, so that we can sort of discuss those issues, so we can all benefit. So we're happy if we share all your details with Libby, and we can all learn from Libby's experience.
Yeah, definitely. That's why I did it, just so that we all would have some answers. So we're starting again. I thought we just need a PhD to allow me to get into the nitty gritty.
Fantastic. Can I just check who's joined us on the phone? Is it Sally or Marie? Oh. Nobody. Okay, right, somebody can't hear us. Thank you so much, Libby, that was absolutely brilliant. I've got loads of questions as well for you, but I'll take them offline. So thank you. Can we hand over now to our colleagues at Compton to talk a little bit, give us an update of where they're at?
Yeah.
And welcome.
First of all, I really would like to say sorry that we haven't been able to set up a presentation for you. Karen's actually joined us, so we're like our second week really of starting to really move forward with our project. So apologies for that. But just to give a bit of context with regards to about our project, and very similar as well to some of the points that Libby's already touched on, we're also, we've noticed we're sat there nodding our heads in agreement because there's a lot of crossover with the work that you've obviously done where we're going to with our project. So our project is obviously focusing around our South Asian communities in Wolverhampton, which is one of the second largest population in Wolverhampton. So we've got quite a very large, diverse community. And for Compton Care, we've really come to a point where we recognise we have huge differences with regards to people accessing our services. So our project is really starting to really understand a little bit more about our communities and how we can start the conversation, the community engagement work with them to not only open up the doors really for people accessing our services, but also having the conversations in the community and to really try and challenge some of the perceptions around the hospice world, but also as well how families and communities can support better. My role at Compton is very much around compassionate communities. I lead the compassionate communities team, so this project sat very closely with myself and how we were going to really engage with that community, and hence the reason why we have Karen on board now, who's our senior researcher for this. What we have found as we've gone through this journey before Karen started is actually this is a real piece of evaluation for us at Compton. I think what was an idea of this research that was going to be something we could produce and inform people of. Actually, we've got so much we have to learn as a hospice as well. So this is really exciting time for us, and I think from the compassionate communities approach that we've taken at Compton, this piece of evaluation and research to really move forward the organisation, but also our communities, and bring us into the communities where we are currently struggling to engage.
Yeah. Just to give you a little bit of context, guys. So I obviously came in last week, really pleased that the project had been funded and that they're doing this. So my PhD looked at South Asian community, community here in Wolverhampton, and experiences of actually dementia and caring for a person with dementia. Lots of issues that have come from the community that this project.
You're just breaking up a little bit. I don't know if you want to sort of speak closer. We're just getting the odd, I'm missing some words.
Alright, okay.
That's better.
Can you hear me now? Is that clear?
Yeah, that's much better.
Okay, alright, I'll start again. So prior to this project starting, my PhD actually looked at the South Asian community in Wolverhampton and experiences of caring for a person with dementia and living with a dementia. And I think this project now is actually a real drive forward since that actual project and the last time I did some research in Wolverhampton around looking at the compassionate communities model. I know that there are additional challenges, which is why I'm quite keen to talk to you, Libby, about your experiences of this particular work, because I know from my work with the Sikh community and the South Asian community in Wolverhampton, there are still assumptions about community support. There's a lot of taboo around particular illnesses, people keeping things behind closed doors. So it's a real opportunity to do some quite, moving, groundbreaking kind of outreach work to bring people out and really get them to be more compassionate. So it feels like the next step. And alongside that, learn what their understanding of end-of-life care is, palliative care, what their needs are, what they require, and how do we empower them. So yeah, I'm really, really pleased about the project. We've got a similar approach, Libby. We have an advisory group set up. So this is about co-production and collaboration, using an advisory group that's as representative as possible of the community, really guide us with how we move this project forward and to learn from them and empower them at the same time to develop champions and ambassadors in the community and see how that works. So that's where we're kind of at the moment. And it started almost last week when I came in.
Yeah. Hit the ground running.
Yeah, so we kind of hit the ground running with it. Hoping to finish in August, and just really excited by the project generally. And hopefully the next time we come in, we'll have some real findings to report back to you, and where we're up to and what we found.
That's fantastic. Thank you. Anybody got any questions? The other teams, St Christopher's, any questions? Any comments from your experience?
Well, just so far that it's I suppose we've taken some of the research and the work that St Joseph's been doing with Compassionate Neighbours and are trying to grow it here in South East London. I suppose the biggest kind of learning curve for me is just the time it takes to build relationships and trust, really. And I think often, everyone's really excited about getting a project up and running and you want to see results really soon, but actually, to get in and build true connections with people where people feel that they're being valued and listened to, it just takes a long time, really. We've just recently worked with I think I said this last time, with a church which has a majority African and also Caribbean congregation, and we were exploring some really fascinating things around death and dying and bereavement, and just trying to find ways to feed that back into the hospice, actually, because there's some great discussions going on and happening outside, but how can we bring that back in and share it with everyone here too?
Yes. As part of, because we've already established the compassionate communities approach here at Compton, we are definitely certainly further ahead than what we may have been if we didn't have this approach as our model. And already, I think the beauty of obviously being successful with this funding, we'd already started doing quite a lot of work already with it. And hear me okay?
No, we can't. You're going in and out again. Don't know what's happening in Compton.
It's not always great here. Can you hear me?
Yep, go on, carry on.
What we've already started to establish was actually already working groups, because we've been with the other funding that we've received through our bereavement information hubs, we'd already started to make quite great inroads into those communities, and we'd actually started the conversation through bereavement with a lot of these community groups. So having the representatives from those different communities have actually come to us already. So part of the work has already been done, which is really quite good, but I totally take on board, I think, is also how we move this forward as an organisation is really important, and communicating it that back and ensuring that people, actually in Compton are also understanding of the needs of people within the community.
Fantastic. Any other comments before we move on to our final speaker, Claire, from anyone?
Just the one thing, I think you're totally right about how long it takes to move relationships kind of looking outside in the hospice. But what was the surprise in my work is that actually, how long it took us to move the hospice along, and those kind of ideas of power shifting, people, we know, we're doing volunteering, and actually this is completely different. And it took me, and I was there from 2009 actually, shouting, and being a doctor, so I could go into all the doctors' meetings and say, look, listen, it's a different, but I still don't, it's taken so long for people to really get it, for the penny to really drop, rather than being like, I can see this, people are a bit lonely, we'll refer in. Like, no, this is different. And so the relationships inside can often be the ones that only by the end of the project you realise they don't know what I'm talking about.
And I'm just thinking as well, we may be useful to cover that at one of the future webinars, but also think about those whole human dimensions and how people see people and how they do take information. So maybe we could do that maybe for the next one. A few of us could, I've got some work on human dimensions I've done, and we can probably share practical tips, which I think might be useful from what you're all saying. So that's fantastic. Okay, that's great. So can I move on to our final speaker, Claire Craig, who I had the pleasure of meeting. And I just thought it might be something useful that Claire's been doing. She'll tell you a little bit about what she's been doing, about live cafes and where that fits. So I thought it might be a useful addition that we might be able to use as part of our different work that we're doing. So over to you, Claire.
Thank you. Brilliant. So as I said before, my name is Claire Craig, and my lovely colleague Helen Fisher, who you also met the other week. Unfortunately, she's not here just at the moment, but I'd like to spend the next 10 minutes giving you a snapshot of a piece of work we've been doing in partnership with Marie Curie. Go for it. Yeah. So we were invited to be part of a project called Design to Care, and that project is really, again, it's interesting. It was calling on some of the things that you referred to, Libby, which was really around a radical rethink. And I think there's probably been a lot of those conversations that have been happening, around, as I say, end-of-life care. Go for it, the next slide. So we were invited because I'm part of, as I said, a research cluster called Lab for Living. We're based at Sheffield Hallam University, and we've been in existence now for about 11 years. And the focus of our research is to bring together these amazing people across fine art, health, design, media, engineering, and to work together in the developments of products, of services, and also of intervention to promote quality of life throughout the whole life course. So we do amazing projects, which we love. But one of the things that I think that I've learned very quickly in terms of design is that design is very good in terms of some of the methods it uses to really engage with people, and to really build and elicit understanding. And a lot of those notions of what is co-production, how do we truly work with people and alongside people as experts and share expertise together to create something new and different. And so we were invited to be part of this broader Marie Curie project, so Lab for Living, and working with Cambridge University and working with the design engineers. And I think the vision of that work was really to create a set of tools and mechanisms to promote change across services, and to try and marry up some of these very diverse services and resources that exist and that aren't always linked together. Great. Next slide. So at a really early point in the project, we did at one of the steering group meetings, we invited people to talk about the resources that they felt were really important. And lovely Alan Kelly here was there, and Julian Abel is part of this. And straight away, Alan was in my group, and you can imagine just the size of that mapping process. I don't come with any expertise or experience around palliative care, so suddenly to start to rethink about all of the resources that are in the community made us feel really excited. So Cambridge kind of took it of the way in terms of working with specialist and I guess more generalist services, but we were really interested in thinking about the community and thinking like, what can we learn from the community? What's happening in the community? How can we tap into some of that knowledge and resource? And really that's been the focus of our work over the last 18 months. Brilliant, next slide. So we did, at the very beginning of the project, it coincided with Dying Matters Week, and we went to lots and lots of great events that were incredibly enriching and insightful. And we went to some of the death cafes, which were great in terms of people talking about death and the importance of that. But after spending quite a bit of time in the community, we realised actually we were missing out on quite a significant number of people who was a bit put off by the title. So what we thought we would do is we would create something called a Life Cafe, where people could come along and talk about meaning and what is important, not just in terms of death, but in terms of life, because actually the two, yeah, there's not much difference really. So we started to work with the communities, and we created a set of tools in partnership with people around lovely creative activities, as I say, that we badged the Life Cafe, and that could form the focus of workshops and groups to promote these lovely conversations about what was important, but also what are the community resources that are available, how are people accessing them, how are people themselves an asset and a resource in the community. So we've had a ball for 18 months, and I don't know if the next slide, there's a little bit of a video. Can I just say to you though, this video, it was made as part of the Marie Curie promotion. It's so unrepresentative of the people that we've worked with, honestly. So I apologise, but maybe it's about 3 or 4 minutes, but it will give you a feeling about what the work is. So I'm going to be quiet. I'm going to let you watch the film. Oh no, there's no sound. If we can't operate...
Sorry. Can you send the link round maybe after?
Yeah. We'll send the link round, I think. Claire will be able to send the link round.
Yeah, that's absolutely fine.
Oh dear, you've got nice pictures but no sound.
Well, it's really funny. Well, maybe keep watching the pictures, because there's some really nice images in there. And
okay, while you're talking over it, that's great.
It's really nice. It's quite nice that you can't hear me going, hello, my name's Claire.
Okay, you keep talking while we see the lovely pictures.
That's lovely. So over the duration of the project, we've worked with probably about, now probably over 200 people in various community groups. And what the Life Cafe comprises of it comprises of a series of creative activities, of things for people to, objects, for people to talk through as metaphors, images, so that people can talk and respond to things in a very visual way and talk through the images or make connections with them. It also includes like smaller things like we've got little buckets for the bucket list and words as responses. So we've got things that people do and that they engage and that they talk through. And what we found within that work is it's just such an amazing and powerful medium to really elicit actually very deep conversations. So you can see some of the people in the images, questions, metaphors, and these become the tools, because we all know how hard it is when people come and they're confronted with either space or silence. And these objects enable people to have meaningful conversations. Every element of the Life Cafe has been created in partnership with people. When we began by just asking people to bring in objects that had some connection to them, that really reflected something about who people were and what they found important in life, in care, and at end of life, based on those experiences. And from those objects, whether they were pine cones or things that made sound, we use those as the basis then to have further conversations. Again, building on that, we did a huge amount of, we transcribed all of the conversations that we had with people, and then we developed themes, and those themes then informed the photographs that went back into the Life Cafe, and the quotes that people had and that gave us permission to use, they formed part of the conversations that we had alongside people. So you can see it's quite an interactive process. And when we started, we thought that the Life Cafe would be a research tool. But very, very quickly, as we were engaging with groups, people were actually asking if they could take them away with them. And I think that was really interesting. They could say, well, when can we have one of these? Can we have a Life Cafe? Where are they available? And through that process, we started to think, well, maybe we should make these into something that is available for people. So if you want to kind of click on the end of the video, you can, as I say, you can see how interactive the whole thing is. When we started, at the time of the earlier presentation, we engaged with 141 participants, and people have come from a variety. So we had people, prison chaplains. We've worked with people at the Somali community. We've worked with people, older people. We've worked with younger people, but all again just using the same method. We've worked in homeless hostels with people looking at end of life issues facing people who don't have a resident abode.
Sorry.
And latterly we've been working in care homes. So it's been a real breadth of individuals. Right, next one. Libby, lots of connections with your themes, relationships, yay. As you imagine, that lot about feelings of agency, lots and lots about the importance of having a sense of control, but also meaning, and people wanting to continue to engage in and have meaning right to the very, very end, because actually that's about people's role and about that's how people have identity. And ways that we can think of that. But equally important, the number of resources that are in the community and the roles that people in those communities are playing, either through being neighbours or through these incredible kind of groups and just who people are. So it's also been about mobilising that kind of support, but inviting people to think about the role that they can also play within the broader community. So where are we at the moment with all of this? Yeah, next slide. So at the moment, you can see this is really the Life Cafe as it stands. So you can see at the bottom, as you're looking at it, the bottom right, there's looking at circles of support and people and places that people might be able to access. We've made the clock. We've got these lovely resource and activities that people can just take around to them. Brilliant. Next one. Yeah, and as I say, you can see some of the objects which embody the findings of the research, whether that's about a compass, which is about navigation and finding your way, whether it's around the environment, through images that people have talked through, or, next one, or through the qualities. So this is an exercise where people write down the qualities that they valued in people, but also the qualities that they have and that they share with others. So there's a whole range of different things in there. So we're now starting to work, not in terms of, still with the communities. Communities are now taking it out and testing it themselves, but it's feeding into both the Cambridge toolkit, which is based, as I say, a lot on service design and those two of the cogs that you described, Libby, but also we're now starting to work with lovely Julian Abel, thinking about how can the Life Cafe fit and offer ways of supporting the operationalisation of bringing people together. Can it sit there, and how can the Life Cafe contribute to some of the work that Julian's doing around building community connectivity? So that's what we're doing, and as I say, we've had the most amazing time, amazing people. It's been a lovely project, but again, fantastic feedback that we've been accessing, and just lots and lots to think about and reflect on. So it's just the beginning. Watch this space, and watch the next part of the adventure. So that's just a little bit about what we've been doing, hopefully, and within time. But anybody, any questions or comments or thoughts? It seems to have married lots and lots of bits about what we've been talking about. So well done, organisers, in putting it together, because it's flowed really, really well. So it's really great that it seems to be really complementary. And lovely hearing about these other aspects of work. But yeah, any thoughts or comments? And maybe we could have a big general conversation between all of us.
Any comments?
Just a question from me, Claire, about the different groups that you worked with. How did you know them before, and how did you connect with them, and why did you choose those particular groups?
It was all kind of serendipity, to be honest. We put out a general call just through the locality, saying to people, gosh, we're doing this piece of research, would you like to be involved? How would you feel about that? And literally, we started with a fantastic group called the Ministry of Craft, who run a community workshop in a place outside of Sheffield in Doncaster. And then from that, somebody said, well, have you thought about contacting so-and-so? No. So it became like a snowball sample, if you like. So it ended up that literally we moved from place to place. And then one of the people within one of the groups worked for the Salvation Army. And so then they put us in contact with the Life Houses, which are nationally where people who are homeless live. And to be honest, it was that open. I think we wanted the broadest spread that we could have, because to understand about what was important to people, we wanted to talk to as many people as we could within the constraints of what the project was. So it was kind of serendipity. It's by no means representative, but actually it's varied, which I think was really useful. And people took to it very differently. There was a lovely moment where in one of the communities we were working, everybody just took all the objects because they thought they were gifts. It was literally suddenly, oh, thank you very much. Everybody took a box, and we were just offering nothing, and we were like going, how fantastic is this? So we learned loads about that process. But I think there's something that's universal in terms of language, and we all interact. We see the experience of the world through stuff, and maybe that's also quite an interesting thing to listen and reflect on. Yeah.
One thing I was thinking when you were talking about just the change of name from death cafes, which obviously people know about and are specifically around dying, to life cafes, and certainly with Compassionate Neighbours, when we started kind of doing some of the really early kind of community dialogue and work out in 2012, what most people spoke about, and obviously death and loss is universal and people could really access that, but for a lot of people compassion was what was uniting, and that was actually what got them involved. So rather than having to say, look, this is all about dying, this is all about end of life, actually it's about living, of which death is a part. And so compassion and the kind of role of being a good neighbour was something that is universal, whether you feel you're doing it well or want to or not, but it's something that everyone does know. And so that was a universal access for everyone, no matter what walk of life you come from. People could talk about what does compassion mean to me. So, and it was less frightening than death and dying.
Absolutely, and it's interesting because
you don't have to brand it about death, because it actually isn't only about death.
Absolutely.
Very, a few compassionate patients are dying, but actually not as many as you would think it was through a hospice. It was much more about long-term relationships in the face of.
Claire, can I just ask a question? Have you done it with sort of younger people, with children?
Yeah, we've done. I mean, the younger people are just great. I mean, they gave us quite a hard time. We should have had Lego in there. But again, really interesting about. And I think we thought it was important to involve younger people because, again, younger people are a key part of community and often don't have an opportunity to talk about what really matters.
I was just thinking in relation to colleagues at Hope, because that's obviously, and Michael, I don't know if you want to come in, but just a general question to all of you is, do you think there's a role for life cafes in any of the work that you're doing, or what your thoughts are about it?
Yeah, without doubt for us. We have found that we've obviously always led with death cafes, obviously recognising probably a little bit more for us as well since our rebrand as well. Hospice, we've obviously tried to re-educate people, make people aware we're not just a death house. So we've moved away a little bit from calling them death cafes, now calling them conversations for life. And very similar to the same theme of yours, but what I've been speaking, I really do apologise. We were so excited by what you were talking about there, Claire. We were also like thinking, well,
we could see you getting excited on the screen.
These are the things that we do recognise, actually, with the communities that we've got to have a conversation, or how we start even this sustainability of this piece of research that we're doing. Where do we go as a community engagement team to make sure that we can continue that reach? And I think the tools that you've used there they are so important, so important.
Steph, what about yourself in St Christopher's?
So is that regards to young, particularly with young
people? No, just generally the idea of the life cafe, and whether you think some of those materials might be useful in the ideas.
Yeah, definitely. I think when we started this project a year ago, we were running a sort of drop-in coffee morning out in the community for people to come and find out about it. And I think what I've learned from that's on hold at the moment. We're hoping to bring something like that back again. And I think there needs some structure. It wasn't enough for people just to come together. People didn't feel useful, actually. That was a big theme that came out of the discussions, because the people who were attracted to the idea of compassionate neighbours wanted to give, or wanted it to be more than just them having a cup of coffee. That seemed quite frivolous. So yeah, I can absolutely see this kind of giving universal and simple things for people to use as tools and prompts is really helpful. And it's something we do in the Compassionate Neighbours training as well, in a different way. But I suppose that, again, as Libby was referring to, opportunities just to talk about things that matter to individuals, really. And it's so varied in every group.
Well, I think just to do it, I run a thing similar to a death cafe here, which we call Death Chat, just because St Christopher's always has to be different. And I think one of the things about death cafes is they demand of people a certain amount of articulacy. You need to be able to talk about. It looks to me that using the tools that you have, Claire, that actually you're giving people an opportunity to talk, using something as a prompt. And that's got to be a good thing. Whether you develop it into a death cafe or not, but I think it enables people who don't feel comfortable to speak to start with to pick something up, offer it as their part of the conversation. Whereas in Death Cafe, the people who can speak most clearly or articulate most eloquently about what's going on for them hold the floor. And that, I think, is a really good difference. And I think it's something which is worth sharing much more broadly.
I'm just conscious we've actually only got literally a minute left now, so because the conversations, I mean, it just seemed to have flown this hour. Claire, I'd be really interested to know, is there any way that obviously as a programme we could get hold of your resources, because I know when I saw the box I wanted to pinch a box and I was told I couldn't because you'd only got one. So it's just thinking how we could potentially get hold of that, and if we as teams want to use that, it would be really useful, because I'm sure that all of the teams would be great if they could have at least one box.
Honestly, just drop me an email and I can
okay.
And that's absolutely, no problem at all, definitely. Yeah.
Libby, would you like one as well if we can get you one?
Yeah, definitely. One last thing I just wanted to say, on Tuesday, so Tuesday the 20th, Public Health Palliative Care International, the association, I'm doing a webinar on evaluating compassionate communities, 12 to 1:30. So if you, it's going to be all about this kind of similar stuff, but we've got an hour and a half to really dig deep. So if you wanted to kind of have an opportunity with international colleagues to pull apart some of the evaluation stuff, if you go onto the Public Health Palliative Care website, phpci.info is actually there, or just email me. I can circulate it if you want, just because
Libby, if you send it to us, that'd be great, then we can circulate it around all the teams. That'd be fantastic.
Yeah, should be good.
Brilliant. Well, thank you very much. I'm going to have to draw this to a close. I think we could all talk for a lot longer. But thank you to all our speakers. And Libby and Clay, you're very welcome to stay and join the rest of the community on another webinar. Our next webinar is the 17th of January. And I think from what I'm hearing, we'll be talking more about the relationships and human dimensions. And it'd be great if one of the other teams could volunteer to talk a bit more about their projects. So if you don't nominate yourselves, I'll come and ask you. Okay, well, thank you all very much. It's been really brilliant. Okay, thanks.
Thank you.
Bye.